So tonight's session is focusing on dissemination implementation science, models, frameworks, and theories. And I'm going to just go to the chat. We'll do this real quick and see if people can get their fingers going. And what I'd like you to type in there is, what do you think when you hear, can't read the whole thing, hear the words models, frameworks, and theories? Let's see what we got. Health intervention evaluation. Aisha, that's a great one. Oops, I sent that just to, I just typed in science. I don't know if anybody else typed anything else in. There we go. I typed it in but sent it only to Emily. All right. Research guidance, good. Framing research ideas, okay, fantastic. So let's move along. You know, I thought really a lot of people can think of different things when you think of models. You know, who are the 10 best models? Well, that's not the type of model that we're trying to do. And do people get my visual gag there with the middle one? It's framework. It's framework. Okay. Thank God that Kiana's not that I could see her, because I could see her laughing. So that is very good. And then theories. You know, I think a lot of times people think of theories. You think of the theory of relativity. You think of complexity and all that kind of stuff. And so I think from our crew here, we got really some ideas about how we would consider theory. So I want us to just unmute yourself for now. And I want you to talk, we're going to talk right now about, participants can now see your application. Could they not see it before? Can you guys see this on the screen right now? Okay, great. Yep. Okay, so what I want us to do is think about just not really anything related to, well, we're going to tie it back to theories, models, and frameworks, but what I want us to do is just kind of talk through and say, what are all the things that are involved if we wanted to make the bell ring?
Fingers.
Fingers, okay, you may need fingers. I'd say that's probably a pretty good, so you can directly, what was that, Emily?
You have to have a bell.
You need to have a bell. That is very true. You need to have a bell.
You need to see the bell.
You might need it. What did you say, Kiana?
A mallet, like to hit the bell.
Okay, a mallet to hit the bell. All right, those are all really good. So I want us to think about, as you guys gave great ideas. I'm going to say that if I wanted to put a causal map, and so when I say causal map, what do people think about then?
Cause and effect. Yeah,
one thing leading to another, right? And in science, when we do this stuff, it's usually not just one thing. Now, I think that Aisha gave us an idea. You could ring a bell by flicking it with your finger, and that's pretty straightforward. Cause, ringing, effect. But we could also think about it as, you want to make a bell ring, you need something that moves towards that bell. Could be a finger, could be other things. You need force that would move that object towards the bell. And then you might need a tool to create force, right? So you guys are going to get to see some of my really outstanding animation work from a PowerPoint perspective. So when I'm thinking about a bell, I'm thinking about this kind of bell. Everyone see this? You can see we're at maybe a state fair or somewhere else. And so if we wanted to make this bell ring, what do we need?
A hammer or a mallet.
A hammer or a mallet. So we're back to Kiana's mallet.
Force.
Force. We need some force. Probably need the little thing that slides up there and hits the bell. So, you know, what we need are kind of the causal factors, the things that are actually going to make the bell ring. And so we could have an arrow, or we could have a stone or some sort of metal object. And then we could also have interventions. And we have interventions that could be a bow, that of course we know where that might match up with. And we have a mallet. Okay, so we might think that with the same causal model or the same causal map, we could ring that bell in multiple ways, right? So here comes my great animations. You guys ready for this? We could shoot our arrow. Everybody believe that'd make the bell ring?
If it strikes and hits it.
Yeah, sure. If it strikes and hits it, great. So then we could also think about our mallet. Look at this animation. I know you guys are amazed. Boom, and it rings. So which one works better?
Mallet.
The mallet, right? The mallet. So if we wanted to take this and think about our, oops. Oh, I did want to give it a little highlight. So one of the things we're going to talk about next week, and this is just a bit of a teaser, we're gonna toy around the intervention mapping a little bit here. But you know, if you tried, so that mallet works to ring the bell through this particular causal factor, which would be the stone or the steel that's on the pole that would ride up and hit the bell. But what if we use the mallet with the arrow? Anybody?
That won't fare well, I don't think.
Right, it'd be pretty hard to get that arrow with any type of force. Remember, force is one on our pathway there. It'd be really hard to get force into that arrow with the mallet. Similarly, it would be hard to get force into the stone with the bow. And so a lot of the things that we do is we try and when we have theories, models, and frameworks, is we're trying to create, in essence, a causal map so that we can say, hey, if we try and make changes in our community, it's going to result in changes in these causal factors or hypothesized causal factors, and that's going to have a change on our outcome. And so we're going to do a small group activity, and since we are a small group, we're just going to do this together rather than going into breakout rooms. And you know, one thing I would ask is if folks do have cameras and you're not, you know, doing anything embarrassing that you don't want to be seen doing, why don't you turn them on? Because then it's a little bit easier for me to see reactions and know that people are hearing me, and especially with this small group activity. Okay, so what we want to do is we want to create a causal map ourselves. And so we have the causal map that I put together for ringing that bell. What I want us to do is start with what's an outcome, what's an intervention, what are the causal factors, and then let's draw it out and talk about it amongst one another. So who wants to throw out an idea for an outcome?
Quality of life.
All right, LeDan, how was I pretty sure you were going to say that? Okay, we got quality of life. Okay, so that's our outcome. So what are things that we, and so it's quality of life. Do we want to specify the population, LeDan?
Older adults.
Okay.
I cannot get creative, can I?
No, this is good. This is what we want. Okay, so we have older adults that we're thinking about quality of life. So let's hear people just come up with ideas, and we'll just start writing them down. What are things that lead to good quality of life for older adults?
Physical activity.
Physical activity.
Social social factors, being able to interact with people.
Okay, social interaction.
I would have said healthy nutrition, but I can't see it moving at velocity, so.
Well, we could think about this is quality of life. So we're going to change up this thing here. So you thought nutrition, Aisha?
Yeah.
So
Yeah.
healthy eating,
Mhm.
put in there.
I say something that stimulates them cognitively, so maybe like reading or puzzles or.
Okay, so cognitive stimulation, and hold on to reading and puzzles. Hold on to that for a moment.
Okay, sorry.
Cognitive stimulation, yeah, yeah. You knew you would. You knew you'd move ahead. Okay, so
How about
then,
independence? Like, would that be too broad?
no, independence, right? That's good. And then, you know, I was thinking, if I can throw out one, I was thinking like mobility. You know, have good
Yeah.
mobility.
I thought about putting a bike in there. So
A bike. Okay, hold on to that bike, 'cause I'm just going to write some of these other things down. So we've got a bike. What you said? Puzzles, and what were the other things you said, Kiana?
Reading.
And reading. Okay. All right.
Socialization.
Socialization. So we have social interaction on there.
Right, right. There.
So, but we can also write down socialization. Okay, I'm going to try and do something a little bit different here for a second. Sorry, you guys, if I can get my slideshow to stop without. Okay, I'm going to stop sharing, then escape from the slideshow, and I'm going to start sharing again. Oops. Okay. All right, so what I'm going to do is we're going to start putting down some of those words. Okay, so for our outcome, we have quality of life. Actually, I should put it here. Okay. There we go. Okay, and so then we said, we thought that there were some things that would lead to quality of life, right? So I'm just going to write here our causal factors. And I should have been doing this before, sorry you guys. Healthy eating, physical activity, social interaction, cognitive, what was it, cognitive?
Stimulation.
Stimulation, thank you. I need some cognitive stimulation myself, clearly. Then we had independence.
And mobility.
And mobility. I think, did I capture everything, even if I didn't spell it right?
I think so.
obviously.
Okay, great. So there we have some causal factors here. Now the next thing that we want to do is, this is kind of in the middle, right? So we've got, this would kind of replace where we have force and object moving at velocity, right? So let's kind of put that in the middle there. Maybe I'll take those two things out for now. Oops. Okay, so let's hear what things would we do? So instead of a selected tool, now let's think about intervention, like interventions that would have an influence on these things.
I would say an education program for healthy eating and physical activity.
Okay, so we could have education.
We can have an app to monitor their activities and daily choices so that it raises awareness, but also gathers data.
Okay, so I put down technology for self-monitoring. How's that sound?
Very good.
Excellent.
Okay, then we had, what did we have? Puzzles and reading. Right, what other things might we need?
You might.
Of course, yeah, go ahead.
No, go ahead.
No, I just wanted to say that, of course, I would throw my intergenerational bonding program in there for socialization.
Great. Intergenerational. Oh yeah, I got it without the red line. Intergenerational activities.
Yes.
Okay.
For some people, home programs, Meals on Wheels, and other things like that would be necessary.
Okay. All right. Any other interventions you want throwing out there?
So
Franco?
for mobility, maybe like a community walking program, walking
Okay.
trails.
Okay, so we got walking program, Walking trails.
I can even think of education about telehealth and using telemedicine would add to their independence if they are less mobile and or cannot have access
Okay.
medical hubs easily.
Okay, so telehealth and telemedicine. Okay, I'm going to stop us there now. So now what we want to do is, now we got to make a map. So we have quality of life here, right? That's our outcome. So what are the things that are most proximal? Like when we think about healthy eating, physical activity, cognitive stimulation, independence, mobility, what thing do you think is closest to quality of life, the most direct influence on it?
Independence.
Okay. Independence. Okay, so I'm going to take independence, and I'm going to take, this takes too long to tell me, but I think we can do this here. Okay, I'm going to, okay, so we got independence. Don't worry, I won't do arrows. I know everyone was on pins and needles going, oh no, he's not going to try and do arrows, is he? Okay, so we got independence. Okay, now is there anything else that we think would touch right up with quality of life in addition to independence, or do we think other things are going to all work through independence?
Maybe physical activity,
Okay,
because if they're sedentary, and they won't have a good quality of life, not mobile, so physical activity and mobility.
okay, hold on. Is physical activity and mobility the same thing?
Not really. I mean, mobility is the ability to move around, but physical activity is something more measurable.
Right. So we think, I'm probably going to have to do arrows. Sorry, you guys. Okay, so we got physical activity, we think is like that, right? But then we also think, I thought I heard someone say that physical activity, maybe it goes there, or maybe we have.
Yeah, to me, all of the other things like mobility, physical activity, and all the rest are kind of under the umbrella of independence. I would probably put independence in the same category as maybe health, for example, or something like,
Okay.
I don't know, something more general.
Yep. Okay, so we could put, I'm not going to let us put any more things on there though right now. Just.
No, I know, but my point is, I think I think mobility would not or may not, I mean, if we're trying to model that, may not directly attach quality of life. It goes under independence. You see what I mean?
Yes, I do. And I made my arrow reflected. So we got physical activity going. But you thought, Aisha, that potentially physical activity could have a direct impact on quality of life as well, right?
Yeah, that's true. I mean, I personally, that's my point of view, but it could be debatable. But yeah, if they're not physically active, there will be no quality of life. That's
Okay.
my point of view. But there are people who are not physically active, and they may think they have a good quality of life.
Okay.
Yeah.
Yeah.
So to that point, my argument is, how can you have high physical activity and not have independence? I mean, in what scenario?
Oh, okay. Well, I guess you could say it. So I hope, I know my mother would not mind me saying this. Over the last 3 or 4 months, my mother moved from living independently to having to move to an assisted living facility. However, she participates in group-based physical activity regularly, 3 to 4 times a week.
Okay.
And so
Yes.
does
Yeah,
she,
that makes
but-
sense.
So it really depends, but this is a good point, Lidan, because it depends on how you're defining independence. If independence means that, she can still live in an apartment, She can, go and eat, she can make her way to dinners and stuff. She can do, she can do everything that she needs to do without really any support at this time. If that is independence, then she's independent still. If being in an assisted living facility, because there's a chance that you might fall again, that you might have something else happen, then, I would say she probably doesn't feel nearly as independent as she did before.
Yeah, and I would say maybe there's degrees of independence in terms of
Yeah.
like a spectrum,
Yeah,
depending on how you want to measure it.
yeah. So we're starting to get some ideas here, but I'm not going to make us go through everything here, but we have healthy eating, which I think we can say would influence quality of life. But the things that you talked about, Aisha, we know from the literature that people that are physically active, that it has a direct impact on quality of life, independent of its impact on mobility. However, some people might define mobility as part of quality of life as well. So it breaks down it comes down to definitions. But the point is that we're trying to come up with a way to categorize this information so that we're going to be able to intervene and have an impact on quality of life. And so if I was just rushing through this, I would probably put that social interaction and cognitive stimulation, I think those things I might put as more direct influence of quality of life as well. So you can be independent, but still need social interaction, still need cognitive stimulations. So we could put some of those things in there too. Now I want us to think about which of the interventions act on which of these causal factors.
I think the intergenerational activities can act on all of them, depending on if those
Sure.
activities are elsewhere, which I imagine they would be.
Yeah. Great.
I would kind of second that with the example of the walking programs, is that could influence physical activity, mobility, and also independence.
Yeah. And social interaction.
Yes.
Yep. That's what I thought. And if you combine the walking program with digital health or mobile health or telehealth and technology, so, for their compliance or to reminders, so that gives you also all of the above.
Yeah. So, when you think about it, the idea is that what we're trying to do is we're trying to make sense of the world, right? And so when we think about theories, and I'm going to get in more detail on theories, what they do is they try and help us put this stuff together a priori. And then we can kind of fill in, the context that goes around that. And so if we would have had a theory of quality of life, which there are some of those things out there, and we wanted to put it in place, we'd then be able to take all the ideas that we have and group them based upon the causal factors that might lead to an improved quality of life for older adults. And I think, LaDan, that gets to your point of, maybe health is a big bucket that has multidimensional that influences quality of life. That if we had a model that could help us to arrange these things, and we wouldn't be having to say, oh, well, Paul thinks mobility influences the path here, and Kiana thinks it influences it there. When we have a theory, we have a place that we can test, and then we test the hypothesis, and it becomes an empirical question of if Paul's right or Kiana's right. And because she has a bigger brain, we know that Kiana would be right. So
I actually have more wrinkles in my brain, but.
All right, so let me go back to sharing the screen here in the big view, and I'm going to move it along. So hopefully that gave you a
Can I
little...
ask a question here?
Oh, please do, LaDan.
So if you are measuring, for example, quality of life, what would you measure? Would you measure all of the components plus, for example, a tool to directly measure quality of life, or what would be the best way to measure quality of life?
That is an excellent question, and I think that I'm going to answer it from my perspective and then see if others have thoughts about it. You know, quality of life is a multi-dimensional construct, and you know, there's physical quality of life, emotional quality of life, social quality of life, and you could think about these as unique constructs. And the downside with quality of life is that the surveys for it are usually super long. And so what I have done in the past and what I've seen others do is they take the component of quality of life that their intervention is intended to change, and that's the one that they measure, and they kind of limit the number of items that a participant would have to answer. Now, where that starts to get tricky is if you're wanting to do cost effectiveness based on quality of life, and then you kind of need one of the like EuroQual or you know longer tools that allow you to do that economic evaluation.
Thank you.
Sure. Okay, not hearing any other ideas on that response. We'll move along and just say, let's jump in the chat again and say, what do you think about when you hear the words dissemination and implementation? Sharing and executing, I like it. Sharing findings and science broadly. Okay, good. After preliminary results, spreading the word about the intervention and then executing it. Okay, those are all excellent. So when I think about dissemination and implementation science and communicating, thank you, Heidi, I think about kind of the gap that we have between the scientific discovery and the degree to which that moves from that discovery into typical clinical or community practice. And you know, there's a nice couple of papers that, and I'm not sure if this has been shortened or lengthened since the time that Larry Green wrote this paper, but that there's a 17-year gap between the time that something is determined to be efficacious and the time that it actually gets into guidelines and in practice. And for some things, there's a good reason for some of that delay, but for a lot of it, it really is kind of just the slow scientific process. And so, you know, when I think about dissemination and implementation science, I think about not just the movement of our findings or sharing of findings, but actually movement of an evidence-based idea or intervention from our point in time that we know it's evidence-based to the point in time that it's applied in a typical community or clinical situation. And so dissemination and implementation science really were, you know, kind of galvanized around the idea of, can we speed this process up so that when we do know that things work, that we can get them into communities and that the communities that we're working with can benefit from them. And when we think about dissemination implementation science and we think about clinical and translational research, it really is kind of near the end of that spectrum, right? Where we start with kind of pre-intervention, that could be mechanistic studies, it could be feasibility and pilot types of trials, till we come up with a candidate health application that we can test in an efficacy trial. And then once we've tested it in an efficacy trial, which means we're testing it under ideal conditions, right? It's the ideal participants. You know, we kind of screen out anyone that we think wouldn't adhere to what we're trying to do, the ideal type of people implementing that intervention. So we make sure we use highly trained professionals to do that, so that everything about the efficacy trial tries to focus on internal validity, right? Can we say when we're done this study that the changes that occurred because of our intervention? And then we move that into effectiveness trials, which now we're starting to get closer to our dissemination implementation types of designs, where we're thinking about, well, now that we know the efficacy of this intervention, will it still work if we let kind of a typical population in? We don't use as many exclusion criteria. We let people in that we think might not adhere to everything. You know, we kind of get a typical group of participants together, and we also may get a typical delivery agent. So if we're thinking about a physical activity intervention that's going to be done in schools, we get typical teachers that would do that intervention. We don't use our highly trained research staff to implement the intervention. And then we start to move into the dissemination implementation world, where we focus on things like adaptation. So how do we take these interventions tested in effectiveness trials, adapt them for fit within typical community settings? And then how do we get it in place in a way that we can implement it with high quality and with consistency, so that we're going to be able to see the same results as we saw in effectiveness and efficacy trials? And then what types of research do we need to, and strategies do we need to ensure that it's sustainable once we get it implemented? And when it's implemented and sustained in one location, what are research methods, and how are we able to move this to a scalable approach where it could, maybe instead of reaching 100 people on average, it could reach 1,000 or 5,000 or 100,000? Or how can we think about it from moving from one school system to 3 school systems to 10 to 20, that sort of thing? So dissemination and implementation, when I think of it, I think about the science that helps us to understand how and why we would be able to make changes and interventions or strategies to address some of these outcomes. Okay, I'm going to pause there and see if there's any questions. And so when we talk about dissemination implementation science, it's really, oh, were you going to ask something, Kiana?
Yeah, I guess I was just going to ask, like, do you commonly see where, because I know, for instance, you know, there will be funding mechanisms that are asking for randomized controlled trials, but then in these trials, they are trying to also do adaptations in the real world setting. So like, there seems to be overlap in those particularly efficacy trials and effectiveness studies. So I guess more or less speaking to the fact of, you know, are they considered one more dominant than the other in those types of situations? Or how does that look, I guess, for researchers that might be trying to do a little bit of both at the same time?
Yeah, so adaptation's a really interesting one. And so Kiana and I are working on a project right now where we're really studying the process of adaptation of an evidence-based weight loss program for Black Americans with the Black community. And so we're focusing on characterizing and specifying how we're doing those adaptations. But when we're done, we're going to do a randomized control trial that will test whether this adaptation works better than the original when people are individually randomized to one condition or another. So in that case, you're really studying the process of adaptation and then looking at the effectiveness of the adaptation as an outcome. And typically that's not an efficacy trial, but you're still, because when you do the adaptation, a big part of the adaptation is, you know, who's going to deliver it and who's going to sustain it, and it's not the research team. So it's typically the community teams. So that's one side of it. And then there's another type of trial that people do around adaptations that are called, probably appropriately, adaptive designs. And so with adaptive designs, you start by testing, and it could still be randomized, where you have folks that are randomized into the adaptive approach and folks that are not. But, you know, with this type of adaptive design, you're typically taking learnings as you go along in your research and applying them before the trial's done. And so by the end, you have an intervention that you're pretty sure works very well because you've made adaptations specific, and you have to have a priori constructs that you're making those adaptations around as you go forward. And some of the maybe I won't get into too much on the there's limitations to it as well as benefits. And the benefits are that, you know, you learn as you go and you take those learnings and you apply them much quicker, right? So that 17-year odyssey, we could really shorten up, because instead of it taking, you know, 5 years, we're doing everything the original way, then we're going to do our next RO1 that's another 5 years that we're going to do it with this next adaptation. We're going to find that works, and we're going to do our next so now we're 15 years and we're still not getting anything. We're not even at the evidence-based intervention yet. And so, you know, so the adaptive trials are really nice, because instead of taking 15 years, you could try and do that in 3 to 5 years and answer the same questions. Some of the limitations are related to the statistical side of things, and I wish Chris was here because he could talk through a little bit more. But, you know, if you're improving your effect size as you go along, you're still using the whole study to evaluate the intervention. And so you might end up with a muted effect size So because at the end your effect size is pretty good, what if at the beginning your effect size wasn't very good? And so you end up with um, a more modest reported outcome. Great question, thank you.
Thank you.
Okay, so when I really like, Jeff Curran did a talk a couple of years ago now, I guess, and then he must have published a paper on it after he did that, but he tried to bring dissemination implementation science down into just kind of more lay language, like what exactly is it? And so he said, well, what dissemination and implementation science is about is sorry, got distracted there. So what it is about is this thing, and the thing is your evidence-based intervention, right? Or and you know, if you're not in dissemination implementation science, you could also think about this as just your intervention, and then we can talk a little bit more about how that might look moving forward. But from a dissemination implementation science perspective, the evidence-based intervention is the thing. And so when we're, you know, one of our projects, Building Healthy Families, focuses on childhood obesity treatment. And so what dissemination implementation research tries to do is to help us find the best ways that typical clinical or community settings could do the thing, right? So how well they can actually get that thing into practice. And then when we think about dissemination implementation science strategies, those are things that it's the stuff that we do to try and help those typical community settings get the thing into place, right? And so an easy example of this would be training, right? So if we have a curriculum that's the thing, then a dissemination and implementation science strategy to try and help staff implement the curriculum is the training approach. And then dissemination implementation outcomes are how much and how well settings are able to do that thing, okay? So that's kind of trying to pull that into a little bit more lay language. Now, this session is on theories, models, and frameworks. And in implementation science, I will tell you, we love our theoretical models and frameworks. And I think at last count, I don't know what last count, but there's well over 70 dissemination implementation science models, theories, and frameworks. So there is a ton, just a ton of these things out there. And I like one of the ways to try and categorize this. Pierre Nilsson wrote up a conceptual paper that talked about really there's 3 different types of models that we would see in dissemination implementation science. The first one is a process model, and that is, you know, how do we actually do it? Like what's the how-to? So a model that says follow step 1, step 2, step 3 to go through this. And then the second type of model he talks about is something that is called an explanatory model. And so it's understanding what influences the implementation outcomes. So this is like our causal factors we were talking about before. And of course, these are proposed causal factors, right? Because we have to test them out and determine if they actually are related. But within there, you can have what's called a determinant framework, which is just, you know, if I have X, Y, and Z, then that's going to determine this, which will determine the outcome. You can have classic theories that give us our constructs and kind of look more like the maps that we did. And you can then have implementation theories that can be applied. So a classic theory in dissemination implementation work is social ecological theory, right? That's a pretty classic one. It's not just an implementation and dissemination theory. But then there's some that are focused explicitly in this area. And then the last type of models and frameworks that he talks about are outcome models. And so, and I label those as planning and evaluation frameworks. And so if we think about that, I'm going to talk a little bit later about our integrated research practice partnership that is our process model. And you can kind of tell a process model because if you look at it, there's going to be something like what we have in the middle here that says, what do you do first? Oh, you do your problem prioritization. Then what do you do? Well, you select your strategies. Then what do you do? Well, you adapt them. Then what? Then you do a trial. And then what? Then you evaluate it. Then what? Then I do the decision making. And then what? Well, I determine what the solution is. And if it needs to go back to the drawing board or can be taken to scale. And then in terms of explanatory models, this is the practical, robust implementation and sustainability model. It's about mouthful, PRISM for short, which is what I'll call it from here out. But this tells us more about concepts and constructs that will help us to reach the dissemination and implementation outcomes that we find within this implementation outcome type of framework. And that this one that I use all the time or very regularly is the REAIM framework. And it gives you a set of outcomes for you to focus on with dissemination and implementation science. And I'll go through this in a little bit more detail. And so the last thing I want to talk about is we've talked about the, there's the thing, which is the evidence-based intervention, and we've talked about kind of models, theories, and frameworks, and then we also wanted to talk about dissemination implementation strategies. And so these are the things that we do to try and help community settings to be able to get good reach, get good adoption across settings, get high quality implementation, and get organizational level maintenance. So all different dissemination implementation outcomes. And when we do this, there's really good guidance for us about how to be able to specify these types of things. And for examples of dissemination implementation science strategies, I've just put a few down at the bottom there, where you can see engage consumer as well. That's, it's really hard to do dissemination implementation science work without having it be something that is participatory and community engaged. Okay, so before I stop, I'm going to stop there and see if there's questions at this point. Hearing none, I will move along. Okay, so again, remember next week we're going to talk about intervention mapping a little bit more, but this should be cueing your mind about this. And so when we talk about an outcomes framework, I'm going to start from the outcomes, then I'll talk about the explanatory, or then the process, then the explanatory, just because I think that's kind of, I always like to start with the end in mind. And so when we think about the outcomes from the REAIM perspective, effectiveness and maintenance are operationalized at the study participant level. And so who's going to have health improved from the intervention that you're doing? So you have your evidence-based intervention, and that's intended to improve outcomes at the individual level and then maintain those outcomes over time. And so that's where your evidence-based intervention matches up. And then if we wanted to focus on dissemination strategies, those are going to look at reach, which is individual level. So how many people, what proportion of your audience, and how representative are they of the audience that you're hoping to intervene with. So reach is kind of an account-based dissemination, and so is adoption, but it is operationalized very similarly, but it's about settings or communities. So the number, proportion, and representativeness of your community setting or your community organizations that are involved in implementing the intervention. And so we have specific strategies that can influence reach, and we have specific strategies that could influence adoption. And then we think about implementation strategies, the stuff we do to get folks to use the thing and use it well, and that is intended to influence the implementation quality, so how well people implement the evidence-based intervention from a dose perspective, from a fidelity perspective in terms of adherence to protocol, as well as a number of other ways that you can operationalize implementation. And it also, these can focus on sustained implementation or organizational level maintenance over time. And so when you think about mapping intervention, it can be focused on the evidence-based intervention, it can be focused on the dissemination strategies, or it can be focused on implementation strategies. And so, again, I'm not going to spend a ton of time on this, but in some of the partnership-based work we've we've used this model for a long time that just basically helps us think about what's on the scientific side that's available, what's our kind of evidence base, and then we have kind of our partnership side. And in this case, it could be healthcare, it could be public health, it could be a community systems, and within there you have delivery sites, you have recruitment sites, you have delivery staff. So a lot of embeddedness in here. But the idea is that there's a partnership between that community side and the research side, and that partnership together really looks to see, can we fit with evidence-based principles? So whatever we're going to do, does it fit with the evidence base? And so again, we're talking about the evidence-based intervention. And then on the community side, we're also collectively thinking, how well does it fit with the system resources and mission of that community organization that may be involved with the implementation? And then together we come up with problem prioritization. And so this really, it links back to the session that I did earlier today, where we focused on generating your research idea and then research question. And this is where, from this model perspective, it's a collaborative approach to come up with the problem as well as the research questions. Then the next step is the evidence-based intervention selection. So again, thinking about what do we have over here from research that actually fits within the community system. And then we also would want to think about our dissemination and implementations strategies, because we also want to know how well those would fit within that system and not have a mismatch. And then once we've done the selection, there's always adaptation. Sometimes it's minimal adaptation, sometimes it's big adaptation. And once that adaptation's done, what we do is what we'd call integration trials. So that's something that we do that's embedded within our community system. And the way an integration trial is done is that if we have the success that we hypothesize, it can continue on in that community without us having to shut it down and then bring it back up to speed, because we've designed it in such a way that it fits within the community implementation frameworks. And with our integration trials, we base those decisions on a re-aim evaluation, and really what the important outcome is to the community to help them make a decision about whether they would need to rethink the idea or sustain and scale the approach. So that's a process model, and you can use it regardless of what your research question is, and you really can use it regardless of what your explanatory theory is, or even what your outcomes model is, because you could just pop in whatever outcomes you wanted to under the evaluation there.
Hey, Paul, would you say that the integration trial is similar or identical to like a feasibility study, or is it different?
It can be, it can be, but it can be a big trial too. Like, in trying to think of when we did our Move More study with Kaiser Permanente, the integration trial was taken to scale in all clinics right from the start, because they wanted there was a pull from the system that wanted a physical activity promotion intervention that could fit within the clinical flow at Kaiser Permanente. And so with that, it was right away from the top. But I could pick other ones where it was more feasibility focused, where, hey, let's just try it in 1 or 2 communities and see if it works there, see if we can iron out the kinks, and then maybe take it to scale later. So it could be, but it doesn't necessarily have to be.
Okay, I just wanted to make sure, because it sounded like it could be, but then I guess it depends on the partners and what they're attempting to do to.
Absolutely.
Thank you.
Sure. Okay, so then we get to this explanatory theory. And I'm going to go through PRISM a little bit later with one of the other examples. But remember, think back to our little circles earlier in the presentation where we had our quality of life outcome, and then we had our interventions, but we kind of built in what the causal factors were. And in this case, I'm calling it a mechanism of action. And so we use this explanatory theory to match up with our dissemination strategies in this case. So in this particular study, one of them was to package the evidence-based approach for easy uptake in small towns and rural communities. This is our childhood obesity intervention, and the outcome here is adoption. So how the number and representativeness of communities that pick up and implement that and begin implementation of the childhood obesity treatment intervention. And so with this one, you can look down in PRISM, we have intervention characteristics that we can think of from both the patient perspective and the organizational perspective of, relative advantage, which means, is it better than what we already have? Compatibility, which is a really good word for the fit within the community setting. The complexity, we know by packaging it, we make it less complex, and less complex interventions are more likely to be adopted. We build into that intervention some observability components where the communities that implement it can readily get data out and see that they're actually having an impact. It's easy to test out, so that trialability, and it reduces the resource cost because folks have that package. They don't have to go and dig around to find a bunch of different approaches to tie together to do a community family-based obesity treatment intervention. And so we can also think about that from the standpoint of implementation strategies. And in this case, we have a systems-based learning collaborative. And the outcome for this one is implementation quality. And in here, the mechanism of action are the contextual factors where we have inner and outer context related to the organizations. And so again, those come from the PRISM framework. Okay, so let's do, again, our small group discussion here. How many models do you need? And again, I'll let you guys just unmute and camera up yourselves. How many models do you need in a community engaged dissemination implementation project? Oops, I didn't mean to do that. Oh, I think I'm getting some chats in there. Oh, it sounds like the start of a joke. 1.
I would say it depends on what your goals and aims are. One might be sufficient, but there might be cases when you would need more than one.
Yeah, I think that's a good reflection on it, LaDan. And I would say that you for sure need one, right? And the one that you need for sure is the explanatory model, right? You need the theory, the thing that is going to, re-aim would be great, but you don't have to use I don't know that you necessarily need an outcome model. If you're going to focus on adoption, you can make a good case for adoption without having to include all of the other re-aim outcomes, right? But what you really need is you need to have that explanatory theory so that you would be able to say why. You need that causal factor, right? Remember our map, we need intervention. In this case would be an implementation strategy. Then we need a causal factor. Maybe it's changes in the implementation infrastructure, and then the outcome, which would be adoption of the evidence-based intervention. So you definitely need one. I would say that in most projects that I do, I have 3 going. But in my research grant proposals, I don't usually outline the process model. I usually just focus on the outcome model and the explanatory theory. So did you say why, Kiana? I think I was reading your lips there. So the reason that we don't usually write a lot about the explicitly about the process model is that it takes so much space. You're now trying to describe an outcome model and a fairly complex, typically explanatory model, and we have a process model. And so what we basically do is we just build our process model into the methods themselves. And so we'll describe the methods without having to say, and we're using this third thing. And I think that it makes it easier for reviewers to understand too, if you just have the explanatory theory and the outcomes, because then you can draw your little pictures like we were drawing earlier. You can have outcome, potential causal factor or mechanism, and the intervention that you're applying.
I figured that might be the case as to why you don't usually talk about it, but just wanted to ask.
Yeah. And so here we have a little bit more on dissemination implementation science models. Boy, this paper, it seemed like it was new, but it's been 10 years since Rachel Tveck wrote this paper. But this was a really good fundamental paper that said, hey, when we hear about theories, frameworks, and models, what exactly are those? And this gives a little bit of a description. I think it's good for folks to know. But really, when we talk about the explanatory models, I'm talking about theories. And usually when we're talking about frameworks, we're talking about outcome models. Because outcome models are also typically planning and evaluation models. And then she just talks about models is often used to describe both theories and frameworks collectively. And I do that. And so I think you've probably heard me start to do that. Now, when we do think about dissemination implementation science, I said there's models that are explicit to this particular research area, and there is some fairly broad level constructs that you can kind of think about here. So the first would be, how flexible are the constructs in it? And so one could be that it's broad, it's loosely outlined and defined constructs, allows researchers great flexibility. This really used to be the consolidated framework for implementation research. When it first was developed, it pulled together a whole bunch of different constructs and put them in place, but there was not really very much in terms of literature on how you measure all these things. And so people were kind of measuring them it was flexible. You could come up with a way that you wanted to assess those things. And then you could have some that were very operational, where you have, validated measures and methods to be able to apply the constructs. And then you have another continuum you can think about that's related to dissemination and or implementation. So remember, dissemination is really about the adoption of the evidence-based intervention, or about the reach of your evidence-based intervention. It's getting that intervention in or out, in somewhere or out to someone. And then you have an implementation, and implementation theories really focus on, you've got it's already adopted. How do we actually get this delivered with high quality? And that's typically an implementation only. And then, of course, you have some that focus on dissemination and implementation equally. The last thing that I wanted to point out here is that social ecological framework really is something that is used a lot in dissemination implementation science, and really from the very straightforward rationale that it outlines things like the system, the community, organization, and the individual. And so when we think about dissemination implementation, you have things at the individual beneficiary level. You have things at the individual adoption level as well. So the staff that would actually adopt an intervention, also at the organizational level. An organization has to adopt likely before staff adopt, although it's not always the way it works. And then you have implementation, again, that can be at multiple levels. So when we think about these types of approaches, we're really thinking along this continuum. And so you might be asking yourself right now, well, this seems like a lot. Seems like a lot, Paul. How many people are saying this theme seems like a lot? Raise your hand. Give me a thumbs up if you think, okay, excellent. Everybody. Well, you know what? It is a lot. It is a lot. There is a lot to think through when we're doing this type of research. And the good news is that there are some tools out there. Of course, you could go to reaim.org. I'm not going to self-promote and send us there in this particular talk, but I really think that there is an outstanding website that was developed by folks at, I think it was a collaboration between San Diego State University, or University of California, San Diego, with Dr. Borshka Rabin, and University of Colorado at Denver with Russ Glasgow and his team. They spent a lot of time in putting this website together. And what this website helps people do is it helps you to really go from how do I plan on what type of dissemination implementation science model I'd like to use, how do I select one that's appropriate for what I want to do, how can I combine models if I need to, because remember we've talked about the potential for having two models. How can I adapt, and what things might I need to think about if I'm going to adapt one of these models? Once I've selected, how am I going to use it, and then what measures are available? And so this, like I said, this will be included. I think the link, I don't know if did someone put the link in the chat? Maybe we can just put that www.dissemination.implementation.org in there. And the next thing I was going to have us do is let's just kind of do a dry run with this. So let me stop sharing my PowerPoint and start sharing my sorry guys. I'm going to start sharing if I can get this. There we go. Okay, I'm right on the precipice of sharing my screen again. Okay, can everybody see the website now? Okay, great. And so this is that disseminationimplementationscience.org, and it's pretty straightforward. They've got some really nice tips on here, and we're not going to go through everything, but I did think that it'd be nice if we kind of went through and looked at, well, if you're trying to pick one of these models, because Paul just drove me crazy, and there's so many of them out there, I don't know what to do. How would I go about that? And so when we go through it, there's some strategies, and if you look through this is more of a question-answer approach that just gives you some things to think about before you actually do the selection. And then you could also, if you wanted to, you could just click on this, and it will give you, I think, if I click on it, well, it's taken a little bit, it will give me all of them. So it just gives you an opportunity to list everything that's there. It has a very nice feature where you can compare models. We're not going to do this one. We are going to go backwards. And can you see the whole screen, or am I moving it off? You can see the whole screen. Okay, great. And so what we're going to do is we're going to do a little bit of a search. And so let's see, Ladan, we've been doing a bunch of stuff on your project. Why don't we pick a model for yours?
Sure, that would be awesome.
Okay, so do you think you want to do dissemination specific models, implementation specific models, or any model?
I would go with any.
Okay, great. So then let's think about social ecological levels. What do you think on this one?
Oh boy. I really don't know. Well, it's kind of, many of it is like, it involves individual, but also organizations, also community.
Okay.
Yeah, I guess for now that would be it.
Okay, good. And so then, the next thing that it says, well, are there any specific constructs that you'd like to look at? And so then it's got a bunch of things listed in here.
Acceptability, definitely, and feasibility.
Okay.
Awareness.
You'd be interested in dose because of the 3 conditions you talked about?
Yes.
Okay,
yes.
Dose. Where's dose there? And I was looking down here where it says quality of life. So
yes, outcome. Yes. And then health. Well, I want to, one of the hidden goals that we have is also health equity.
Great.
But yeah.
All right. Okay, should we go for it? Do you think we have enough on there?
Yeah, for now, yeah.
Okay, so let's see what we get. Let's see, hopefully we get a... Oh, so you got 29, so...
Wow.
Yeah, it is. So you had 29, so if we want, we could go back and say, are there other things we want to click on here to see if it'll limit it a little bit more for you?
All right, then in that case, external validity generalization, definitely.
Okay.
Pre-implementation,
Where do we
um, barriers and facilitators,
Okay.
process, stakeholders,
All right. Shall we try again?
complexity,
Oh, complexity. We'll try complexity, and then let's try it again.
complexity and cost, and engagement.
Cost and engagement. Now let's see if we've ruled them all out. See if we get less than 29 this time.
I'm saying 5.
Oh my God, we got more.
Just kidding.
So I think one of the things that we've discovered is that it's an and.
Right.
So
Yeah.
if we click on ands, and so it might be better for the for you as you go forward to go back and say, well, what are the and let's do it right now. Let's go ahead and say, okay, so we've tried this out. We realize that it's an and function. So now let's really get at what the absolute key is.
I would say outcome.
The outcome, the quality of life, will keep that.
Yes.
Accessibility, feasibility, you said that.
Yes.
Awareness right away. Health equity, we know that's the hit. We're going to keep that. Come on.
I would say take everything else away.
Okay. Let's see what we get. Okay.
Take external validity, generalizability.
Oh, I left that in there. Well, we're back to 29.
Oh, wow. Okay. Well, take awareness away. How about just keep outcome and see what happens?
Oh, okay.
Outcome and acceptability, these two are, I would say, these are the most important.
Okay.
Oh my God. Okay.
So, but look at the very first one, practical, robust implementation, of sustainability model. So that's one that we've already reviewed. The nice thing about that one is it also includes re-aim. So, but you could go through this and at this point, as somebody that's new to the world of dissemination implementation science, Lidan, you could just start with the first one, read it, and see if it fits. Then I would look to see, well, how many other people have used it. So if you look on here, times cited, so you got 180 there. It's newer. The pre-seed model 132. So trans creation framework of community engaged behavioral interventions to reduce health disparities. That sounds excellent, but it's only been referenced 19 times. So if you take that to a study section, that may or may not be helpful. So then I'd really think about that one. Then we have Proctor's implementation outcomes, which are just outcomes and doesn't have the explanatory theory. So that one I would rule out. So there's some ways that you could go through this. EPIS, this is a really good model, highly cited. It's been around for a while, but it's implementation only, doesn't include dissemination. And so you might not want that. So the idea is that you could go through this, and even though there's 20, I bet that you could go through and identify one relatively quickly, just using some of those.
Was PRISM both?
PRISM is both, yeah.
Okay.
But it leans towards implementation. I guess that's what it got a lean sign on there.
But a lot of her constructs that she was looking at before we narrowed them down are in this one too.
Yeah, it's got the quality of life right there. Yeah. All right. So, that just gives you a sense of, we took, 5 minutes and went through that. And, we were able to narrow down pretty quickly for Lidan, a handful of, I guess, 4 handfuls, technically. All right, great. So I'm going to stop sharing there and go back to the slides.
Can I ask
Please.
maybe irrelevant question? How does pragmatic study model compare with all of these models?
It compares really well, and much of dissemination implementation, as well as community engaged research, is pragmatic in focus. And so, pragmatic really incorporates, it's not just one thing. There's a lot of different dimensions of a research trial that can either be more explanatory or more pragmatic. And so, but most things that are pragmatic are more generalizable, focus more on external validity. And so, it tends to be that D&I, as well as community engaged research, does end up being pragmatic trials. And is it next week we get a talk on pragmatic trials?
No, it's day 4 with
Day 4.
meeting with the researchers.
So in 2 weeks, Dan,
Yeah, 2 weeks.
we'll get someone that will give you a better description than I just did. Okay, so we're coming down to the wire here, because we know last time we killed everybody going to the end of the day. So I want you to do, we have one poll. I only have one poll. How do you feel about picking theories, frameworks, and models? And it should pop up here any moment. Look at that. And let's get everybody to vote. Yeah. Okay, I got 4 votes in there. There's our 5th one. Okay, I think I'm gonna enter there. All right, so some commonality. A lot of people, great. Gives me a better sense of why they're needed. So that's good. Good, but it's still really confusing. I completely get it. And hopefully we can continue to make it a little bit more digestible for folks as we keep going forward on the Institute. Again, very happy that nobody said, it's way too much. That's very good.